Right. Our next presenter is going to be joining us virtually. She's been doing a lot of travel and picked up a bug she did not want to disseminate, so we appreciate her consideration. But it is my pleasure to introduce Professor Rosalie Pacula, who holds the Elizabeth Garrett Chair in Health Policy, Economics, and Law at the Saul Price School of Public Policy at the University of Southern California. She previously spent 21 years at the RAND Corporation, consulting on drug policy. She has done a lot of consulting to international associations, including the Centers for Disease Control, the World Health Organization. She has a long track record in this space, and she's going to be speaking today about expanding and improving health regulation of cannabis.
Well, thank you very much. And again, my apologies that I can't be there in person, but I'm very grateful. I'm getting a little echo. Is that it's better now? Okay, great. Thank you. I do want to provide a little bit of disclosures. I have, as was mentioned, conducted a variety of studies and testified to various government agencies with significant funding from NIH in general, but I do not have any industry contacts and no other conflicts to disclose. I do want to acknowledge, though, in the work that I'm going to be presenting today, the focus on public health regulations is really work that I've been doing with a body of researchers in Canada and the US, and I want to give acknowledgement to them as well as NIH for the funding for this particular research. As Heather Kimmel suggested yesterday, there has been a substantial amount of rapid change in cannabis policies in the United States for a little bit longer than even Canada, which is why at times people have looked at the United States for evidence of the impact of some of these cannabis liberalization policies. The problem, we do have a lot of variation and a considerable amount of research has evolved, but unlike Canada, we don't have a federal partner in these policies, so states are adopting them for each by themselves. Nonetheless, there's been a body of evidence that's grown from the 25 years of experimentation in the United States that suggests that changes in cannabis liberalization, particularly legalization, and I will also echo Daniel Myron's comments of commercialization, are generally associated with a rise in adult use, a rise in dependence. We've seen a rise in cannabis-impaired driving, increased use among pregnant women, and a rise in emergency hospital visits related to a variety of conditions that are similar to what you've seen in Canada as well. But even in the US, there remained a number of inconclusive areas of impacts, primary one being youth. Some studies suggest no impact on youth. Some suggest that liberalization policies are associated with a reduction in youth use. Others have shown that liberalization is associated with an increase of certain at-risk youth. And so the findings have been somewhat inconclusive as was echoed by Andre McDonald earlier today. There's a lot of interest on the impact of these policies on the use of other substances, and there the evidence is highly mixed. When we think about the potential public health impacts of these liberalization policies, it's really what's going to happen with these other substances that a lot of people believe is going to be where the weight of the harms or the benefit of this liberalization policy exists. And there are a number of reasons for these inconsistencies, and many of them have been brought up in the past 2 days. The problem that across surveys and across different data sources, there's a tremendous variability in the measures of cannabis use that get used. Any use in the past year is probably not a great indicator of potential risk of an adverse ED visit. Whereas weekly or near daily use might be a better indicator for that use. But when there's inconsistency across studies, both in terms of the measures as well as in the outcomes, it's hard to disentangle why studies are inconclusive or why certain studies may or may not be comparable. There's also tremendous variability in the cannabis products used, not just in the product, but in the mode of administration that can have potential impacts on public health. And then finally, both those first two have been widely discussed already in the last 2 days in the various presentations. But the variability in cannabis policies specific to public health really hasn't been given as much attention, I would say, in Canada or even in the United States. Daniel Myron's work, which I've always been a huge fan of, I think does a really tremendous job of trying to differentiate the legalization of cannabis in Canada from the commercialization. But even that term commercialization is actually embodying a variety of different aspects of commercialization that need to be considered more carefully and thoroughly when you're thinking about particular public health benefits or harms. So that's really what is going to be the focus of my talk today. I believe these regulations are really important because, before I discuss what they are, I think they're important because we know from alcohol, tobacco, even from sweetened beverages and other caffeine, social norms get influenced by the regulations we set around the products in terms of how much we're comfortable using, the frequency of use, the mode of administration, where we use these products, these sort of behaviors, which are important for understanding whether cannabis use is just a casual recreational activity done in moderation or potentially a harmful activity done with high potency products on a daily basis. Those two behaviors are not the same thing, and they can be modified by the public health regulations that the user is living within. Available products is another excellent example. Everyone was talking about the difference advertised in storefronts, as was raised by Dave Hammond yesterday. So these sort of variants in aspects of the local environment are really important. And then, of course, as an economist, I would be a bad economist if I didn't at least talk about the role of cannabis prices. But in the case of a product that is going from an illicit market to a legal market, it's really hard to talk about the role of cannabis prices and keeping them high because the simple production costs plummet with legalization, and there's no way we can tax the product up to the point of where they were illicitly. And if one of the goals is to get rid of the illicit market, I would say we don't even want to do that. So what I want to point out is that the specific cannabis regulations adopted in each of these areas that can influence norms, available products, outlet density, commercial marketing, and cannabis prices all are important, and yet many of them have not received the attention that they need in research. Let me point out one more example before I start talking about what those regulations are. And this is one I think that is relevant for Canada in particular. With my colleagues, Tim Mamie, Jason Blanchett, Rosanna Smart, and others, we took a look at the legal limits associated with sale of cannabis as of January 1st, 2020, across the 9 states that had enabled adult use of cannabis. And what I'm showing you here is for each of these 9 states, the sales limits as specified in the statutory law for flower, which generally range from 1 ounce to 2.5 ounces of cannabis product. It didn't distinguish dried from fresh. Concentrates in terms of grams, which range generally from 5 to 8 grams, although with Michigan on the higher end and Nevada on the lower end. And then some states did also provide restrictions on the total amount of edibles that could be sold. These generally also reflected restrictions based on amounts. Only a few states considered edibles in terms of the amount of THC in the edible. And why I think this is interesting and important is not, if you look at each of these on their face value, these look like relatively small quantities. And if you think of that amount, that can be purchased in a single transaction by a given individual. But what I like to emphasize is that an ounce of flower, when you're buying a 10% THC strain, is fundamentally different in terms of the doses of THC than an ounce of flower at the 30% THC level. And state laws have not been thinking about that when specifying sales limits in their legalization documents. And so what we did was go across these 9 states, and we used the average potency of products, flower, concentrates, and edibles being sold in Washington state. And we didn't look at just the average. We wanted to look at the full distribution and see how many doses of THC could be purchased with these different state laws that don't look they don't look vastly different. You might think, oh, Michigan's going to be a little big, but other than Michigan, they don't look all that different. If you were to buy the lowest potency cannabis, the highest potency cannabis, and something in the middle. And so what I'm showing you here is the results of that. It's just a simple math calculation, applying the typical distribution of potencies that were observed in Washington state, which was the only state for which we had comprehensive seed-to-sale data where we could know what the average potency was of these different products. And what I'm showing you here are box and whisker plots that show on the low end, the lowest potency amount of THC in each of those flower, concentrates, and edible products versus the highest amount of THC available in Washington state for each of those products. And then the blue box in the middle is showing you the median value, the 25th and the 75th percentile. And what I hope you can see here, Michigan, not surprising given their somewhat larger amounts, can generate a very vast variety of doses depending on the potency of the products that the consumer chooses. But in all of these states, there's not a single state, if someone were to go in and buy simply the median potency product available in Washington state, they would get, at a minimum, more than 500 10 milligram doses of THC in one single transaction. Is that a lot? Well, if you compare it to alcohol, which given in the US, we were supposed to regulate cannabis like alcohol for the vast majority of states that chose to legalize, a keg of beer holds 165 12-ounce servings. And every state in a single transaction in the United States that are legalized up until 2020 was allowing 3 to 5 times that amount for average potency products. So we worry about spillover into the illicit market. And what I raised to policymakers when I show them this slide is, when you are setting up sales or possession limits, and you do so ignoring the product for which that is being regulated, you may be missing in important ways what might be allowed to be purchased, and it might be more excessive and setting a norm of use that is much larger than what is desired by the community that is choosing to pass these regulations. I don't think anybody would be shocked to know, in the US, we're pretty good at regulating who is allowed to get a keg. We have keg registration laws. We want to make sure that we understand that, somebody who's buying this amount of alcohol is doing so in a responsible way. Why not consider that for cannabis as well? Cannabis is not a singular product. My colleague, John Calkins, I have to give him full credit for this, does a tremendous analogy of cannabis to say it's really a class of products. And the analogy is to dairy. Dairy is a whole bunch of different products too. And some people who have intolerance for dairy don't do well with any of it. And you could say the same for people who are at risk of certain conditions with cannabis. But there's some dairy products that are really quite healthy, that are deemed to be good for your health. And there's other dairy products, such as my favorite form of ice cream, gelato, that's not so good for your health. And to call it all the same product and regulate it as the same product is actually not doing justice for the benefits or the harms that can be caused by this heterogeneous class of products. And these sales limits focused on quantity instead of on potency of the inherent intoxicant in the product is a reminder of that. So what elements of cannabis policy really matter for public health? You have in Canada a tremendous experiment going on with federal regulations setting some of the regulations related to marketing and to product the quality is being checked at the federal level. And then there's some variation that we know exists across provinces. And I stole this slide from Health Canada presentation because I think it does a really great job of identifying some of the different aspects of regulation that we think of mattering for public health. Minimum legal purchasing age, which is higher in Quebec than in the other provinces now, not initially, not when it was first legalized, but now that is the case. Physical outlet density and who owns those outlets, who's in control of them, whether or not there are additional restrictions in terms of personal cultivation or product restrictions, and not represented here are some of the additional limits that could apply to possession, which, as I just showed you, may translate to significantly reduced amounts of THC available for either individual consumption or diversion to the black market, as well as use in public spaces, which is important for setting those social norms. So we have the same problem in the United States, but at a much greater level because we don't have a federal partner in our implementation of our policies. And so we went to a group of experts in alcohol, tobacco, as well as cannabis, and asked them what elements of regulation do you think are going to be important for influencing adult excess use. We're going to assume adult moderate use is what is desirable with legalization, but we also presume, based off of information that was in many of the state laws, that excess use, even among adults, was not deemed to be appropriate. There should be certain guardrails in place. So what sort of public policies would be important for reducing excess adult use, reducing youth access and use of cannabis, as well as reducing impaired driving, which was a critical concern in many of these states. Again, all of these presume that legalization is going to generate significant benefit in terms of reduced criminality associated with possession and arms, and those are truly important benefits, as others have raised. Increased employment and revenue, these are all positives. We are just thinking about what sort of guardrails do you put in place to protect public health while also accomplishing these other benefits of legalization. And you can see the group of experts that were drawn on for this list. And let me just go down the 18 areas of regulation that were deemed to be important based off of their knowledge of alcohol and tobacco. Advertising restrictions, you in Canada have much better restrictions than we do here in the States. Cannabis possession limits, the example that I provided already. Clean indoor air and smoke-free laws, which could be important for cannabis in particular because of vaping, not just combustible. Cultivation and manufacturing operation restrictions and requirements. Are good manufacturing processes required? What sort of testing is required? Delivery restrictions to consumers. Now in the US, some areas do allow for home delivery, others do not. It's not based on medical or rec, it's just based on the jurisdiction's own regulations. Home cultivation restrictions, which often are in terms of the number of plants or the size of the area that can be used for home cultivation. Impaired driving laws. Medical cannabis restrictions and requirements in terms of who has access and to what products. Unlike Canada and the US, we didn't, again, have a federal partner, so these were highly variable across the states. Packaging and labeling restrictions and requirements, previously discussed, can have important implications for the consumer's knowledge of how to use the product. Penalties for adult use and possession of cannabis, important for distinguishing decriminalization policies from other liberalization policies. As Daniel Myron mentioned earlier this morning, you can obtain some of the criminal justice savings by simply reducing the penalties, criminality associated with possession. And states in the US have varied significantly in that. Physical retail availability and hours of operations, things like that. Product design restrictions, retail price restrictions, retail operations, state monopoly, which unfortunately in the US we don't have any examples, but obviously you do in Canada. Taxes, track and trace requirements, which could be valuable for identifying where there might be opportunities for diverting legal product into the illicit market. And then youth policy. So here are 18 different areas of regulation that have been studied not necessarily, not in cannabis yet, but in alcohol and tobacco, and have been shown to be important for influencing adult use, youth use, and harms associated with this use. And yet in cannabis, we've paid very little attention to the variability that exists in many of these areas of regulation, particularly in the United States. I want to talk briefly about product design restrictions and requirements. Again, in Canada, there's better regulation at the federal level, but there's some, as we've seen between Quebec and the other provinces, some variation that exists. By product design restrictions and requirement, when we were looking at the state laws, what we were thinking was the extent to which a state put a cap on different types of products that could be sold, a potency caps in terms of THC. Now, we were doing this in 2019 and 2020, where US states hadn't quite done this yet, but we had seen caps placed in Uruguay and in Canada, and we were optimistic that states might choose to do the same, and indeed we've seen a few states do so since, and so we were happy we incorporated it. Whether or not products that are used orally or in liquids could be scored or delivered in individual servings that are easily identifiable, whether they look like regular food products or do they look distinct. So once unwrapped and put on the kitchen counter, might they be mistaken for another food that other child, a teenager, or someone who's not aware might consume? Caps on the total number of servings. In Canada, again, the regulation is much more restrictive. You have a cap of 10 milligrams per package. In the United States, in edibles, the maximum allowable to be in a single package is 100 milligrams of THC. So we are hoping to see some variability across the states in that. Whether or not the product can be mixed with alcohol or tobacco, we think this could be important for setting norms and potential harms or benefits. And then whether or not products can be designed to appeal to children. And as we've seen in the US, very similar to Canada, this is a rule that most states adopt, jurisdictions adopt, but it doesn't necessarily prevent the industry from creating the products. So the bottom line is that jurisdictions may have very rigorous controls across all of these dimensions. Canada's would be deemed highly restrictive based off the scale that we have. But in the US states, there's actually quite a bit of variability in what is going to be included. And so we had a rank order, as we did with our experts, what would be the most important aspect to create a restrictive score. For each of our 18 regulatory areas, we did this. So what I'm showing you here is just for one dimension, the cannabis product regulations. If cannabis was not allowed to be sold at all, if it was not legal, they got the most restrictive score with respect to product restrictions. And again, you could argue whether or not that's a good idea because goods are obviously being sold in the illicit market, but from a regulatory framework, they weren't being very restrictive. Or they were being very restrictive in not allowing any products sold. And then we weighted the relative importance of some of these other aspects in terms of the three outcomes that we were interested in. Higher potency products getting greater weight, as would state laws that prohibit mixing cannabis with either alcohol or tobacco in a way of reducing harms. Whereas other things like the scoring of individual servings weren't given as much weight because of this concern that once it's unwrapped, I don't know about many of you, but I can easily eat a whole Hershey bar, even if it's scored to serve more than one person. So why is this implementation of these different public health regulations important? We have these 18 different areas of regulation that we obtained with our experts. In each of those 18 areas, we ranked how restrictive or less restrictive they were. And we wanted to know how did these change over time, because in the US, medicalization of cannabis is a very variable policy. And just saying a state is medicalized doesn't sufficiently distinguish states like California and Colorado, where the medical market was fairly liberal in terms of the conditions and the relationship with doctors and the allowable products, versus a state like New York, which had much more rigorous laws in place in terms of requirement of a existing ongoing relationship with a physician, no flower products allowed to be used in the medicinal market initially, and the like. And so understanding the potential spillover benefits or harms of these policies without understanding some of these nuanced, important differences in what was happening in these markets would cause people to put New York and California in the same analysis as a treated medical cannabis state, when the implication on potential harms would be very different for these two states. So our big push in paying attention to these different areas of regulation is to do a better job of describing where is the variability in these policies and what sort of policies are more effective for improving public health and which ones are least effective at improving public health. So we put all these 18 together and we looked at the score. We analyzed state laws going all the way back to 1990. We developed the restrictiveness score for each of the 18 areas. In the US, we dropped monopoly, so that's why you're only seeing an average of 17 policies here. And we looked at how restrictive were states over time as our liberalization policies continued to evolve. By 1999, we had at least 6-8 states that had medicalized, but more than that, we had several states that had decriminalized. So our restrictiveness score was high, but not close to 1 overall, because we had things like possession limits in it. 2009 represents a really important year in the United States, because prior to October of 2009, there was considerable uncertainty about how specific states could be in their regulations of medical markets at the time in light of the federal prohibition. States had to walk a very thin line of providing enabling legislation that would not make them come into direct conflict with the federal prohibition and be liable should the federal government decide to sue. This changed dramatically when the Obama administration came in. In October of 2009, the Attorney General wrote a memo saying basically that they would allow states to experiment with medical cannabis policies and other liberalization policies, provided that patients and suppliers were in strict compliance with the rules of the state. Well, that meant the state actually had to clarify what those rules were. So this memo passed in 2009. You see a bunch of regulation being introduced and changed in 2010. And then we start to see greater changes in how restrictive or relaxed states are in their cannabis legalization overall. There's a little bit of a change between 2009 and 2019 when you average across all policies. But when you look across individual areas of these 17 areas of regulation, you actually get some interesting differences. Product design, which I mentioned earlier, started as very restrictive because most states didn't say specifically any rules regarding products, again, trying to avoid conflict with the federal government. But by 2019, there was a loosening of the restrictions related to product design as more states regulated, and they defined what they meant by these products. Very few states, you have to realize, in our U.S. system capped potency at this point in time. But the change even in this product design wasn't even as significant as changes in, say, the medical cannabis restrictions and requirements. There we saw a much bigger change in the specificity of state laws and what was being allowed in medical cannabis markets, both the patients allowed, the amount grown for medicinal use, and the types of products that were allowed. So lower number here means less restrictive. Similarly, we see a reduction in the restrictiveness of track and trace requirements, the regulations pertaining to that, while other areas of regulation, clean indoor air laws and impaired driving in particular, saw increases in the restrictiveness. So it's important to recognize, even in the US states where it felt like everything was becoming more lax, there were actually certain areas of regulation that were becoming more restrictive that could have important implications, particularly if you're looking at, say, impaired driving as a relevant outcome. So how important are these areas of regulation in terms of influencing outcomes? Because we didn't have a big body of research to base this on, because people hadn't been paying as much attention of it in the cannabis space, we used modified Delphi process to ask the experts what they thought would be most important for each of these regulations in impacting, again, excess use among the general adult population, youth use, and impaired driving. And what I want to point out is while some areas of regulation are important and uniformly more restrictive policies are deemed to be effective at reducing each of these three outcomes of interest, other regulations, advertising, clean indoor air and youth policies, for example, are deemed to be more effective by the experts in influencing youth access than they are in terms of adult excess use or impaired driving. And so maybe when we look at evaluations of the impact of legalization or these aspects of regulation on outcomes, we should be paying attention to those in particular. And things like impaired driving aren't expected to affect adult use, excess use in general, unless people are allowed to consume on site and drive home. But in the US, that wasn't one of the common regulations, so it wasn't deemed to be very effective. It was just mostly going to be important for influencing impaired driving. So we have been collecting this data. We've been calculating the implementation over time that has been changing significantly. We have from our experts what we think the efficacy of each of these areas are likely to be for three primary outcomes of interest. And we construct from this a comprehensive measure of the overall cannabis policy environment from a regulatory environment perspective. Why do we do that? Because it's quite possible that areas such as Quebec, where we understand there's less commercialization because they have fewer edible products allowed. They don't allow those. They have a higher minimum legal purchasing age, and they have lower density. Perhaps those are the factors that are really driving the reduced harm that we've seen in some of the earlier analysis presented by Daniel Myron. Or maybe there's other factors of the general environment that we haven't yet thought of that are also part of that general environment. And it's only through describing the overall environment that we can ask those questions of what elements of public health regulation really matter the most. So we got to start with a comprehensive assessment. And so we construct our score using our efficacy rating and our implementation rating for each of these 18 categories. In the US, it's 17 because we don't have monopoly. We sum this up, we normalize it to set it so that we have a range in the score from 1, which is the least restrictive, to 100, which is the most restrictive. And we can calculate in any given year what the median cannabis policy environment is like. On average, in the US in 2019, which was the year for which we had the most recent data, we are still deemed on paper to be a fairly restrictive environment, but there's a lot of variation across the states, with the lowest state not being California, much to my surprise, but Nevada, Indiana being the most restrictive. So let me give you a little insight into what this CPS scale looks like, and then if I have time, I'll try to talk a little bit about our findings. But what I'm showing you here, we created this cannabis policy scale that's targeting first adult use. That's the dashed line here. We do it for each year. Youth use, which is the gray line, and impaired driving, which is the lower line. And you can see in general, these scales tend to move pretty similarly together. So for the rest of the presentation, I'll just be talking about the general adult use scale. As you can see, this adult use scale didn't change very much, even though we had a lot of medical cannabis policies changing early on until the Ogden memo came about, at which point we start to see more specificity and changes in state cannabis policy environments. And they continue to change overall. Now, this is an aggregate of all 18 areas of public health regulation for all states. What does it look like between individual states? And so what I'm showing you here is the average cannabis policy scale for an individual state, all 18 areas for each state. In 2009, which is shown, the value in 2009 is shown as circles. The value in 2019, 10 years later, is showed as X's. And what you can see here are some really interesting things in my mind. First, you can see about a third of the states in the US have generally very restrictive cannabis policy environments. And most of these are not states that are just strict prohibition. As I showed you in the map earlier, and Heather showed it earlier as well, there are changes in medical environments, but these states that have moved in these medical environments are doing so in a much more restrictive, limited way than what was initially happening in states like California and Colorado, which I highlight here down at the bottom. Even in 2009, before legalization, they had fairly low CPS scores, compared to all the other states. Montana is this weird outlier, and that it actually is one of the few states that became more restrictive over time. But what you can see is that there's been a lot of variation, even within states, in the extent to which regulations are becoming less restrictive. And that variation could have important implications when thinking about public health harms. Just being a first mover doesn't mean that it's not a very restrictive state. Washington State, I'm highlighting here, in 2009, well into its medical cannabis program, was still much more like the other states than it was like Colorado or California. And what's interesting, if you were to compare Washington State as a first mover, a state that actually had relatively loose regulations, to other states, what you would see is that it really depends on what state you compare it to. Michigan also adopted medical cannabis law in this 10-year period, but had very little change in its overall restrictiveness of its regulatory environment, unlike Washington State. If you talk about policies as a simple dichotomous indicator of medicalized or not, recreationalized or not, you lose a lot of the description of the regulatory environment that could be important for understanding use. We showed that here in a separate study where we looked at these CPS scores on average by state, comparing it to states that had not adopted any no decriminalization, no medical, no recreational markets. Those are the blue states. States that had decriminalized or removed the criminal status of possession of small amounts of marijuana are shown in red. Medical cannabis states are shown in green, and by 2012, we're looking at state laws as of January 1st. No states have legalized. But what you can see is just even within the 7-year time period, there's a lot of variation in medical marijuana states and how restrictive they were in terms of their variation. This is, again, box and whisker plots. Some states are highly restrictive. Other states are not very restrictive at all. Median value is pretty significantly different from either prohibition states or decriminalized states. When we look at states with legalization and take it out to 2019, you now start to see an even greater spread in how states are choosing to legalize cannabis. And so in the US, when you're looking at the impacts of legalization on youth use or on impaired driving or on ER visits, it could really matter if you're looking at a restrictive state versus a less restrictive state compared to some medicalized states, because some medicalized states, even in 2019, are fairly close, according to the general policy environment, to recreational states. So given limited time, I'm not going to have time to show you some of our results of how the CPS score appears to be correlated with particular outcomes. In general, what we're seeing is that the CPS more restrictive scores are associated with reduced adult use and reduced cannabis-related fatal accidents in our FARS reporting system. But the point of this is really to raise this insight that researchers need to be paying more attention to how states are regulating. I teased you by saying, what are good public health regulations? The reality is we can't answer that question yet because we're only just beginning to understand the full regulatory environment. Once we've defined the full regulatory environment, which is what we're doing with the CPS score, then we can start to see, okay, which of these public health regulations within the CPS are really driving the correlations with either public benefits or public harms. Canada is in the same space. There's lots of interesting variation across the provinces, but if analyses are too focused on dichotomized, particular hypothesized mechanisms and ignoring the other aspects of the cannabis regulatory environment that could also be important for setting norms, setting exposure, or potential risk of diversion to the illicit market, then we're not doing an adequate job of really understanding the implications of that specific regulation of interest, whether it's outlet density or the allowance for edibles and the like. And so I'm offering this more as a suggestive way of asking researchers to start engaging in Canada and describing the overall environment. Only then will we be able to have a better understanding of how to tweak the existing regulations that exist in Canada to provide more of the benefits and reduce some of the unexpected harms that we have been seeing from cannabis legalization policies. And I am going to stop there despite having a whole lot more and take questions if anybody has any.
Hi, thank you so much for a very interesting presentation. If I understood correctly, the CPS is a composite measure, the components of which all contribute equally. And you alluded to the fact, I think, that there would be value in trying to better understand if some of the components had a larger association than others, and that might give you an opportunity to create some kind of weighted score. Have you been able to look at some of that to see if some of the individual components show stronger or weaker associations with some of the outcomes you're interested in? I know you said overall you've looked at the CPS score, but have you been able to look at some of those individual components?
A great question, thank you. We are delving into that, but let me correct you with one point. We don't actually weight each area of regulation equally. We develop a restrictiveness score in each of the 18 regulatory areas, and then we weight that implementation score by the efficacy that is deemed relevant from our modified Delphi process. So the efficacy, for example, of our adult use CPS score of impaired driving, that's given a lower weight than taxes or retail price restrictions in the construction of our composite score. We haven't seen as much variation in some of the things that are given higher weight. For example, right now we don't have any state monopoly. So the weighting right now, which is based off of, again, expert opinion, this is really, the expert opinion was drawn on knowledge and experience, both alcohol, tobacco, and theoretical principles. So we do need to do a detailed analysis of the relative importance, empirical, of each of the different public health regulations. At this point, the weight is based off of these efficacy ratings, which are based off of expert opinion. Now that more data are becoming available and we have more availability in the scale, we'll be able to look a little bit more closely at our particular areas of regulation.
Thank you for the, thank you for the clarification as well. Just one sort of quick follow-up. Is there a possibility that some of the contributory items actually might not be particularly important? Are there some that you feel might end up falling out once you're able to look at the individual associations, or do you feel fairly strongly that all of these components are likely to improve the overall associations?
It's a great question that I think it needs to be answered empirically. And part of the reason why I don't have that answer for you is that trying to identify the right outcome data to test this on, you would think you would want to look at it for a variety of different outcomes, some survey data, some administrative data, and the like. And the best survey data, from my perspective in the US, to evaluate state-level policies is the National Survey on Drug Use or Health, which is state representative surveys of consumption. You can only gain access to the geocoded data by going through a census department, and it's a very long, drawn-out process that was made even more complex and difficult during COVID. And so we are just now getting into the census to do this work, and we can't report the findings until they've been released. So this is ongoing work. We intend to have answers in the future. Right now, we can only do suggestive comments. And at this point, we're basically relying on what we know from alcohol and tobacco to be effective in terms of determining excess use of cannabis among adults or youth.
Thank you for a wonderful presentation. I have two questions. The first pertains to state monopolies, and I think I just heard you say that there are actually no state monopolies for cannabis sales in the US. So does that imply that Quebec is the only place globally that has a state monopoly for sales and distribution?
Well, some would argue that Uruguay has one in their sales through the pharmacies, and those are government-run agencies. So Quebec is unique in that it is a state monopoly at the wholesale level, not at the federal level, and it will be interesting to see what those implications are.
Do you
Statement-
foresee
I should clarify,
future state
statement
monopolies in the U.S. Catchment area?
only if federal legalization comes about, because without federal legalization, there's the risk again of a significant lawsuit. I should note, though, our cannabis policy scale is encompassing cannabis, and there are examples of state monopolies from, medical cannabis, and there are examples internationally of state monopolies for medical cannabis, Bedrocan, for example, in the Netherlands and the like. So state monopoly is something that we know from alcohol to be a very important and effective way of keeping price artificially high and access somewhat limited. So we have hypothesized that would have reduced excess use, but that will be an empirical question. And we might not be able to answer it in the US if the federal government does not legalize. So we're limited in what we can examine in the US because of the prohibition.
Thank you. One more question. We've talked a bit at this conference about education for bud tenders in retail settings. And in general, there's a lot of misinformation, a lot of lore and mythology about cannabis effects, benefits, harms. Are you aware of any differences by jurisdiction in terms of certification for cannabis education or training, and how that may affect positively or negatively?
Yeah, we are seeing that in the United States already. That's part of our retail operation restrictions and requirements. An example being in our medical cannabis stores, certain states require that a pharmacist be present and be the one be able for consultation of patients as they purchase. That is not uniform. That, for example, is a policy in Utah. Other states are starting to develop curriculum for bud tenders. The efficacy of that is unclear. I remember yesterday in one of the presentations, there was some talk in the chat saying Alberta is starting to do education for bud tenders, even in Canada. So yes, this is something that we've included in our implementation rating and assume that if it's part of the regulatory structure, it could be protective. But how much of it exists, how much variability is it in the United States right now? It's largely reflecting variability with respect to our medical policies and to a lesser extent, the recreational adult use policies.
Thank you.
Hello, thank you for your presentation. I work in a public health unit here in Hamilton, and so, of course, I believe that a public health approach is very important. I'm curious, though, in the 18 areas of focus for policy, I don't see anything about treatment. And I know that treatment's very important if you think about nicotine replacement therapy or counseling. I think it's important that public health advocate for funding for treatment, but I don't see that in the list. I'm curious what your thoughts are on that.
It's a great observation. We don't have prevention here either. And many would argue prevention is an important part of any public health strategy, and I wouldn't argue with that in the least. Prevention is not on here at all because we, when we were working with our expert panel, could not come up with an agreed way of recognizing prevention activities in legal statutes because it's so diverse, so heterogeneous. Treatment, however, is represented in a couple of these regulatory areas when taxes can be used to support treatment as well as prevention. That our tax regulatory area gets an increase. It's viewed to be more restrictive when tax dollars are going towards treatment than when tax dollars aren't being used for, they're just getting put into the general pot. So that's where treatment at the moment is represented. It's inadequate by many standards, but part of the reason for that too was a discussion among the experts of whether treatment, if we don't know what efficacious cannabis treatment looks like, then why would funding treatment as an explicit part of the state regulation be better or worse if we don't know a priori what treatment looks like and whether it can be effective for different groups. I think as we have continued to, as the sciences continue to evolve, we are clearly seeing a lot of people showing up in treatment in need of cannabis use disorder, and obviously behavioral therapies have been helpful for some. The question is whether or not we know what good treatment looks like and to what degree would that get represented in the state law. At this point, all we know is that allocation of some of the revenue that the states glean from legalization may be transferred into treatment, and that's represented in our taxes implementation score.